Good evening, everyone. And again, welcome to Antioch's Summer Health Series. As you all know, our theme is aligned with our church theme. So I'll just reiterate on what our theme is. 2024 Antioch Summer Health Series theme is embracing the fear of the Lord as a guide on your path to a holistic health. This evening, we will speak on common childhood illnesses, and we have our very own Dr. Pullins in the house who will be interviewing our guest, Dr. Kruger. But before we get started, I'd like for us to, as we do always in the house of the Lord, is to bow our heads. For those who are in virtual land, if you could do so, close your eyes, make your mind clear so that you can absorb all of the information that you will be given this evening, and I'll be preparing our prayer. Heavenly Father, we ask that you touch our messenger and our messages that we receive today. We ask that you give Dr. Pullins the opportunity to ask the right questions and to allow those who are hearing the information to receive this information in an appropriate manner. We ask that each and every person that's in virtual land and that is in house, that they are able to hear the word, Lord Jesus. Though these are physical terminologies and medical terminologies, we also want to incorporate and make sure they understand the spiritual side as well. We ask that you continue to bless this congregation from those who from birth all the way to the older age individuals. We ask that all of the information that's being delivered, all the common childhood illnesses from the heart to the lungs, to the legs, to the joints, to the brain, that they are all received in an appropriate manner. And we ask that you touch the listeners, Heavenly Father, that they're able to ask their questions that are needed to be answered, and those that are not able to receive their answer, that they are provided the resources, Heavenly Father, that you wish for them to ask. We ask that you bless this evening and all the other following evenings to come, and we ask that you continue to bless this congregation. Amen.
Thank you, Dr. Allen, for that introduction and opening prayer for us tonight. So again, thank you for coming out again. This is our 18th Summer Health Series, so we are getting closer to 2-0, and I said that out loud, and I said, wow, time has flown. And so this has definitely grown from the early days to where we're at right now. So I'm hoping that you are being blessed by what has been shared so far. And tonight we have another great topic. We thought to take a different route on tonight, just because we spent a lot of time over the years dealing with mostly adult-based care and not been touching on the childhood. So we thought we'd take a different direction on there. So that's what we're going to get into. But before I do that, I did, as I was thinking today, did want to take pause because today is a historic day, not just for African Americans, but I think for the entire world. And so many of you know today is Juneteenth. And so just a history background on it, that was the day in Texas and around 1865 when the Union soldiers came around and told the enslaved people that they had been freed. And this was 3 years later, after 1862, after the Emancipation Proclamation occurred. And so we want to take pause and not just rush over that, because, had that not happened, the United States wouldn't have benefited from the many gifts and talents of African-American people had that not happened. So I definitely want to make sure I give pause to that before we get started tonight. All right, so tonight we have a special guest. This year I was led to stay at home with my guest list, and I have many talented people within my department at work that are more than capable of speaking on topics. So last week we had Dr. Mike Underhill come out, and we talked about what it meant to be temple steward keepers and how we should look at preventative health and things we should know that have changed in the approach to wellness in general in the health system. So on tonight we have Dr. Kelly Kruger, and she has a interesting background. Her father was in the Army, so she spent a lot of time going around the country in different places. But she ended up going, and if you guys can bring up her bio, I appreciate it. She ended up doing schooling out in UCLA and in DC, and she got board certified in both internal medicine and pediatrics. So she has a double board certification. And so she's able to take care of the young and the old, and she spent time doing that training. She's been very beneficial to our department in helping, because at Mayo Clinic, as you know, we mainly see adults, and we specialize in the serious and complex. So we don't have a lot of pediatrics, but she's been instrumental in helping us increase some of the pediatric population at Mayo Clinic. And she joined us in 2018 and came on, and she's done a great job and risen in leadership. She's been married for 16 years and has 5 children, which that alone, to me, she has my respect to work full time and have 5 children. So first, let's give a hand to Dr. Kruger and welcome her here.
Thank you, Dr. Pullins, and thank you to the community for having me. It's really a joy to be with all of you tonight.
Well, it's good to have you. So let's delve into our topic tonight, and we want to talk about common childhood illnesses, and we have a lot of, whether you're a parent, whether you're a grandparent or a guardian, these are some things that tonight that we really want to talk about. But before we got into the illnesses, we kind of want to talk about checkups, and particularly in early childhood, infancy and childhood, there's a lot of things that need to take place, need to make sure that the child is developing appropriately. So we'll start there, Dr. Kruger, if you can kind of talk about checkups, if we can go there first.
Absolutely. So in pediatrics, we do a lot of checkups. We do a lot of preventative care in general, right? So by the grace of God, many children don't have a lot of chronic health conditions that we're having to manage, but it is just as important as ever to make sure that we're still bringing them in for those routine checkups, because there's actually a lot that happens in those checkups, even for kids that are super healthy, right? So believe it or not, from the time that you walk in the door with your child or your grandchild until the time that you leave, there's a lot that is being assessed and addressed during those 20, 30 minutes, whatever the time that you have in there. And so there's a couple of things that happen really at every visit when you are being seen for a checkup. We look at things like growth, for example, right? So, and there are some things that are checked every time. So things that seem basic, like height and weight, and for young kids, right? We look at the head circumference as the kids are squirming on the bed, right? So we measure that head circumference. But we really do a lot to follow those trends, because how kids are growing really tells us a lot about their health overall. We also look at some things like development, like you mentioned before. From the age of really kind of birth to 5, there's so much development that happens that is so important, and we want to really make sure that we're keeping a close eye on development. We also look at checkups as an opportunity to really screen for some childhood illnesses that come up. We do a lot of talking and partnering with families about what's to come, right? So even if everything is going great, it's really nice at a checkup to be able to say, here's what I would expect in the next 3 months. Here's what I would expect in the next 6 months, a year, right? So, and finally, I would say that I think checkups really provide an opportunity for us to really model what it is to our kids or our grandkids, the importance of health, right? And from a very early age, right? This is an important relationship. This is someone that you really want to build a relationship with, that you can trust, that you can ask questions when things come up. And I think even if there's nothing present at the time, we know that those relationships kind of build on one another over time. And I think checkups really give us an opportunity to do that.
So you mentioned several metrics. You talked about head circumferences, height, whether they're meeting developmental milestones. Can you give me an example of one of those that's abnormal, and why is it important to catch it early?
Absolutely. So when we are looking at young children, for example, we measure height or sometimes length if the kids aren't able to stand just yet. We measure weight and we measure head circumference. And we follow those things over time, right? So for anybody who has taken their kids or their grandkids to the pediatrician or the family medicine doc, you know that we talk about percentiles sometimes, and we'll say, oh, my child is on the 50th percentile, or my child is on the 5th, or my child is on the 95th. And actually, whatever percentile they're on, I tell families, the 95th is no better than the 5th. This is not a race, right? So the most important thing is that we are consistent with our growth. Because when we start to see kids who, let's say, fall off of the curve, that's what makes us start to wonder about what else might be going on. So if I have a child who comes in and they are measuring, let's say, at the 50th percentile today, and then let's say they are measuring next time they come in at maybe the 30th percentile, and then 6 months down the road, the next visit, they're measuring at the 15th, right? Then that really has me starting to wonder what could be going on in there. Now, there could be a lot going on in there, depending on the age of the child, depending on what might be going on physically. Maybe there's a physical problem. Maybe they're not absorbing well, right? So maybe there's not a lot of access to food in the house, right? So maybe there's something psychological going on. Maybe there's stress at home, and the child's response to that is to not eat well, right? So there could be a lot of reasons why someone's growth would be changing, whether it's falling off of a curve or whether it's jumping up and kids are gaining weight. But I think when we follow that trend, that's what really clues us in to say, this is important, I need to do a little digging and figure out what's going on.
So, one thing about children, particularly when you're caring for them, they don't always express themselves like adults, so you can't necessarily depend on them to tell you something is wrong. So it seems like what you're saying, the reason why it's important to take your children regularly, because we can pick up patterns of things and then catch things earlier before they become an issue. I'm assuming, is that what you're saying?
Absolutely. There's a lot we talk about early intervention a lot in pediatrics, and that's a concept, the idea being the earlier you catch something, the sooner you do something about it. And that's true in adult medicine too, but it's certainly true in pediatrics. If we can pick up on something that might be happening, because to your point, children may not have the words to be able to express themselves at an early age, and sometimes they can't quite figure out what's going on with themselves physically. So it's really up to us as clinicians to help them figure that out. The earlier we can notice those changes, the faster we can start evaluating and figure that out, and the better the kids will do.
So before we move on a little further with the more on infancy and the young child, any questions from parents or anyone at this point? Yes, sir. The mic is coming your way.
Yeah, Dr. Kruger, certainly appreciate you being here. From a standpoint of pediatrics and children's age, when does a child go from, I guess, a pediatric doctor to a primary care physician or a physician in adulthood? Is there a time frame for that?
That's a great question. So I would say there's not a hard and fast cutoff. Let's start with that, right? So because there are a number of different clinical settings in which kids can be seen, right? So when we speak about primary care, that's a term I use a lot, right? So a primary care clinician. That can actually refer to a pediatrician, so someone like myself who is a physician trained in pediatrics. That can also be a family medicine physician, so take Dr. Pullins, right? A physician trained in family medicine. Both of us can be primary care clinicians for a child, right, of any age. And then we also have primary care clinicians who are not physicians, but who are sometimes nurse practitioners, sometimes physician assistants, right? So, and all of these people can be primary care clinicians for kids, right? When it comes to how long you can see somebody in terms of age, right? So that depends a little bit sometimes on your training and your level of comfort, if you will. So if you are in family medicine, right? So, or if you are trained in pediatrics and internal medicine, as I am, you can see patients from birth until death, we say, right? So you can run the gamut. If you are only trained as a pediatrician, then sometimes the age at which pediatricians like to graduate their patients out oftentimes is somewhere between the age of 18 and 21, but that can really vary. There's no hard and fast rule about it. It really depends kind of on the practice and where you are. So,
and then sometimes the maturity of the child, because sometimes you'll have a child who's 16 or 17 and they're like, I don't want to go to a little kid doctor anymore, and they want to change. So it can vary, too, on the child.
For sure. That's it, and that's a great point.
Yeah. Yes, we have a second question.
As far as measuring, like, internal development, I know typically at pediatric appointments, they do, like, the weight and things of that nature. But how do we determine if our child is healthy as far as, like, they're getting enough proteins and things of that nature? Because I know at the younger age, they don't do blood work. And I have a child that doesn't eat meat. So I don't know how to tell if she's, like, getting the right nutrients.
So that's a great question, too, right? So a couple of thoughts I would start with. We put, when it comes to evaluating nutrition in kids, right, and whether they're getting enough, you're right, we don't routinely do blood work, kind of every year blood work to check on general things, the way that sometimes we do for adults. The reason for that is that most of the time, most kids are normal, right? And so it's kind of thought of, in most healthy kids who are eating a balanced diet, that it's thought that that's probably not necessary. Now, there are some caveats to that, right? So we put a great amount of faith in weight and weight gain and those growth curves that I mentioned at the beginning. So when a child is growing well and following their growth curve, that's very reassuring to myself, Dr. Pullins, and others that this child's health is okay. But that being said, if we know that there are deficiencies, let's say, in the diet. So let's say you have a child who doesn't eat any meat at all, right? So, and if I'm concerned, that is a great opportunity to bring that up when you're talking to your child's primary care clinician and say, hey, I'm concerned my child eats almost no meat, right? Or whatever it is. It gives us an opportunity to sit down and review the specifics of, okay, they don't eat meat? Do they like other sources of protein, right? What does the rest of the diet look like? And then sometimes in those cases, we will screen for things. So if I'm worried that a child's really not getting any meat at all, maybe we will screen for anemia, right? And we know that at times in pediatric development, actually anemia, some kids are at higher risk. And so sometimes we will screen depending on where we are. But even in a specific case like what you're mentioning, it's a great time to raise that and then partner with your clinician to say, hey, I'm concerned, should we screen for this, right? And then sometimes we balance, what does that look like? Screening for anemia is a blood draw, right? Or maybe a finger prick, and we talk through that, so.
That's a good segue into, but we have a question here, and then we'll go on to that.
Yeah.
probably have a lot of questions for you tonight. I just
That's
spent
why we're
2
here.
weeks with 4-month-old twins, great-grands. And so
congratulations.
got a lot of questions. But so far as growth is concerned, my granddaughter is breastfeeding the twins. And they're 4 months old. Well, they're 5 months old in a couple of days. And I'm concerned about her intake so far as the children's nutrients that they're receiving. How important is that? Like she likes sweets. She's eating sweets. She's eating healthy. She eats a lot of vegetables and the white meat. However, I'm concerned about the ice cream, the chocolate, the cookies, that sort of thing. How important is that?
That's a great question, and probably a little difficult. I don't know if she's listening or not, right?
I just said
'cause
she's
doing a
listening.
great
Be
job.
careful. I just said.
But it is a great question, because one of the things that we talk about in pediatrics across the board is that when you are taking care of kids, you're actually taking care of families, right? You're taking care of the kids and their parents, or whatever the family unit is that they're coming to you with. What I would say about breastfeeding, so breastfeeding is a fabulous way to go, right? So it really is what I recommend, and it doesn't work for everybody, but if we can do it, it's really fabulous for kids, right? So in general, moms who are breastfeeding, right? So the body is designed in such a way, right? The Lord has made it so that you will take from yourself and basically make what you need to feed that baby, right? Which means that those babies, and if there's 2 babies eating, then there's enough milk generally made to feed those 2 babies, right? So, but on the flip side, then I do often counsel my breastfeeding moms, to say, we have to make sure we take care of you too, right? And what that looks like is, yes, I want you to eat a healthy diet, right? So, is it going to be a problem for the kids if the mom is eating a lot of sweets? Specifically in that, there's probably no data that I know of to support that, but do healthy eating habits in the parents impart better eating habits for kids down the road? Yes, right? So that part is important. I would want to make sure that mom is drinking enough fluid. That's really important for breastfeeding moms. Hydration is really important, right? We want to make sure that mom is keeping up with her hydration. The other thing that I do recommend is I actually recommend all my breastfeeding moms to keep taking that prenatal vitamin that they were taking in pregnancy, because I think that helps, especially through the breastfeeding process, to just ensure that you are getting what you need. We all like our sweets. I also recognize that if she's a breastfeeding mom and she's breastfeeding twins, there's a lot going on. And sometimes we don't have the time to maybe cook as healthy as we'd like to. And so that's fair too. And so I think the prenatal vitamin helps a little bit in that as well. So, yeah, of course.
We're going to keep going. I see we're going to have some questions tonight. Let's talk about the well-child visits in general, like maybe what happens to them other than the measurements, maybe the frequency of the scheduling.
Absolutely. So we do a lot of well-child visits early on, right? I would say if you think about, for those of you who have kids in the room, if you remember when your kids were young, like under 2, you felt like you were always going to the doctor. There's a couple of reasons for that, right? So we do that because number one, there's a lot of growth that happens in that time. The time between birth and 5 years old is just chock full, and the rate of growth is so fast. And so we really want to make sure that we are keeping a close eye on that to make sure kids are growing and developing normally in that time. So most kids will come into the pediatrician maybe at 2 months. Well, let me back up, right after birth, right? So then we'll often have kids come in about 2 weeks or so to make sure that the feeding's going okay and everything's on track. And then we'll start seeing kids every couple months. So usually 2 months, 4 months, 6 months, 9 months, and a year. And then we'll usually go 15 months, 18 months, and then 2 years. And we do that, number one, to follow the growth, And then number two, because that aligns often with the timing of recommended vaccines that we give at the well child visits, right? So there's a lot of vaccinations that are given for vaccine preventable illness that we give before the age of 2. And so we really time a lot of those vaccines to be given at those well visits, right? So remember that vaccines really do prevent against some of the common childhood illnesses that we'll talk about tonight. And a lot of that, I always remind families too, that even though we don't always see these vaccine preventable illnesses anymore, a lot of times that's because we are given the vaccines pretty widely, right? There may be some in the room that remember times before when everybody got measles, right? Because that's what happened, right? And now we don't see measles much anymore, although sometimes we do, right? But again, that's often because when the rates of vaccinations fall, we start to see some of these vaccine preventable illnesses again. So really the timing of those well visits is really timed to keep us on track for vaccines and also to check in on the various aspects of growth and development that we're looking at.
So I know with the, since we've moved to vaccines, there was a slide before this we were going to go to first, but yeah, so we're going to come to that. But on the vaccines, there's a lot of pushback after the whole COVID-19, the pandemic and all that kind of stuff. And so what I have found that even in parents now, there's more pushback on childhood vaccinations, even though, you know, we've prevented a lot of illnesses that children would die from in the past through that. Can you speak a little bit to that, what you would say to the parents that maybe have concerns about getting their child vaccinations updated?
So this comes up a lot, right? So, and what I would say, my approach, and my approach with many things, including vaccines, is that I really try to walk alongside families, right? And I really believe very much that we are best served when we meet people where they are, right? And that because I think generally speaking, my concerns for the health of that child, the parents have the same concerns about the health of the child. And so we can talk about kind of where we're not aligned, right? But if I remember, these parents are having these concerns because they're coming at it from a good spot, right? So their heart is in the right place. I think that's a really important thing for myself as a clinician to remember. And so I will often ask parents, if parents say, no, I'm not doing that, then, or no, we don't do that, then I will often ask, let's talk about what concerns you might have, right? Because not everybody's concerns are the same, right? Some people's concerns might be with one specific vaccine, others might have concerns about all kinds of vaccines. There's a lot of information available to us these days, right? Some of that information is good information. Some of that information is totally off base. And so I think it's helpful to get a sense of where somebody's coming from, right? The other thing I will say about vaccines, so then if families have specific concerns, I will try and speak to that, right? And say, you know, if there are concerns about whether vaccines cause the illness they're trying to prevent, as an example, right? Well, I know I gave my child the flu shot and then they got the flu, right? Or I gave, measles vaccines might cause autism. I heard that somewhere. Or my child, my nephew got the measles vaccine and then he was diagnosed with X, Y, or Z, right? I think it's important to know where people are coming from and then to try and revert back to the science of what we're talking about. We don't always come to agreement in that first visit. Sometimes we don't always come to agreement at all, right? But I do find that over time, as we can have a conversation with it, I think that fosters relationship there, and then we can hopefully continue the dialogue. So I think that's oftentimes how I will approach it.
Okay.
So,
thank you. So we deal with kids, in the early stages, and then they move on to the school time. And so I know a lot of times when we see children, we ask about, school performance. And there's a lot in those answers that we get on what the parent and sometimes the child will give us. So let's talk about, how that relates to when you're seeing a patient or a pediatric patient, how you utilize that information to give you some insight into what may be going on in the home or what's going on even in their health?
So I remember as a trainee when I was in residency for pediatrics, I remember one of my professors telling me, when you are taking care of kids, it's your job to get them to be functional adults in society. And I think about that sometimes, and she said it much more gracefully than that. But the point is that when you are taking care of kids, you are keeping an eye out for their physical well-being, but they're also really helping to shepherd and partner with the families on their emotional and academic well-being so that they can, if they need to, graduate out of that pediatrician's office and into an adult office and be able to do what they can do. Now, we recognize that's not always possible, right, depending on what's going on with a child, but I really do think that we have a responsibility when we take care of kids to ask how they're doing in school, right? Because that tells us a lot. It's important that we try to set them up for success in school, so that's going to set themselves up for success later in life. So I think it's important to ask. And I tell my students and I remind myself, you need to ask how your kids are doing in school every time you see them. And you've got to be specific, right? So if I say to my teenagers or even my school-age kids, how are you doing in school? They'll say, I'm good. And then I'll say, well, tell me what good looks like. I don't know. Well, that's not good enough, right? I need to know, tell me what your grades looked like, right? So tell me, did you get mostly A's, mostly B's? What'd you get your A's in? What's the hardest class for you? And then I always ask, what was it like before, right? Particularly if I'm hearing something that's not so great, right? Because changes in school performance can actually, just like growth changes, can really clue us in on something that's going on, particularly for kids who are growing up. So I will tell you, a couple of weeks ago, I had a young lady in my office who's in 8th grade, and it was the first time that I was seeing her. And I said, how are your grades? Well, we got through all that. She said, I'm mostly D's and F's. No, that's not so great. So I said, well, tell me about that. What was it like, let's say, in 6th grade? Oh, I got A's and B's in 6th grade. Well, that's a big red flag to me, right? Because now I've got A's and B's 2 years ago. Now I've got D's and F's right now. There's a lot that could be going on. Maybe there's something that's purely educational there. Maybe there's something social going on. Maybe there's something going on at home, right? Who knows? But there's a lot to unpack in that, right? So in this young lady's case, we spoke a lot about all of that. She's really dealing with some mental health challenges, some bullying at school, and mom didn't really even know about that. So she knew that the grades were bad, hadn't really stopped to unpack why things were as bad as they were. So that's an example that I give, then I think about her a lot, that school performance can sometimes be our first clue that there's something that we need to look deeper at.
You talked about the timing of talking when you get home with the children. And I was listening to a podcast the other week, and it was talking about how to create safe environments as a leader for your audience. And it was the guy talked about how his adolescent daughter, if he asked her when he picked her up from school how things were going, he got a one-word answer. But if he waited to 10 o'clock p.m. when he was ready to go to bed, and he talked to his daughter, it was a whole nother situation. She wanted to talk for an hour. And so the point was sometimes you have to talk to people on how they want to be talked to and when, and sometimes you get more information. So I think sometimes even as physicians, when we have adolescents, sometimes it's hard and that's why sometimes we ask the parents to actually leave the room at one point so that we can kind of get the true answers there. So the good points. What else is for school performance are we looking at other than the things that you mentioned? I mean, is there other things that you're looking for? You talked about the grades. Is there anything else as far as bullying, other things that you may also look at?
Absolutely. So sometimes when if you have a child who is struggling in school, right? So there's a lot to unpack there. One of the things that I think is, if anybody in this room has ever had a child or a grandchild who has struggled in school, you know the importance of advocating for your child in the classroom, with the teacher, and with the school. Some of our kids, even outside of something really, a bullying or a mental health concern, some kids, if they're just struggling with, let's say, a learning disorder, right? So something that can be fairly common like dyslexia, right? So that can impact school performance, right? And it can take us a while to unpack that and to get to the root of what's causing that, right? So maybe it's not something that's going on at home or a bullying or anything. Maybe it's just that that child learns in a different way. Getting to that, right, and advocating for your child, it takes persistence and it takes time. But I would encourage you to, if you have concerns about how your child is doing in school, to raise those concerns early to your child's teacher, to your child's guidance counselor, to the school, wherever you are, and to be persistent in those concerns, because sometimes we know that they're not always heard right away. Sometimes we need to involve specialists to be able to perform a larger assessment about how your child is learning, right? So, and how they are reading, and then to help us put together things like an IEP, for example. For those of you who are familiar with that, an IEP is an individual education plan that we put together for children who maybe do have some disabilities in learning or in their style of learning. And so that's a plan that we can work together with the school on. And it is the job, I think, of the primary care clinician to partner with families and to advocate for that child in getting the resources they need at the school. I say that knowing what that takes for families. And so if you're sitting there thinking, gosh, she makes it sound so easy, it's not. And I know that. And I do think, though, that it's really important. It's my job to advocate, and I would encourage families to advocate for them as well.
Any questions there? Okay.
I have a quick question about, you were talking about the kids graduating from your office to maybe the adult doctor. Are there any laws against or for the children that are like mentally challenged when they get to the adult age? Are they allowed to stay with your office if they are used to being with you versus going on to an adult?
So it's a great question, and it's one that's kind of near and dear to my heart, because as Dr. Pullins knows, I have kind of a special interest in that kind of transition period for children or young adults who are graduating into the adult world, particularly for those who have maybe a chronic illness that they've been managing, right, during childhood, and that could be any number of things. To the question about specifics about laws, there aren't any laws specific to allowing or accommodating young adults with illness that would, let's say, have to stay or be allowed to stay in that sense with a pediatrician's office, right? So it really has to do with that pediatrician's level of comfort and relationship with the family. I have absolutely seen pediatricians who will keep young adults with, let's say, some chronic illness, particularly maybe with some developmental delays. I've seen them keep those kids in their practice for a while, right? So I now take care of a young woman who's almost 30, and she just came to me because she was being followed for so many years. And let's face it, when you are the parent of a young adult with chronic illness, and if you have been through the ringer and back again with your child and with that physician, you don't want to leave, right? Like, leaving is scary. Jumping out to the adult world can be really intimidating. I do think that in most cases, it is important to make that jump if you are not seeing somebody in the pediatric. If it's only a pediatrician, you're going to want your child to see a family medicine physician, an adult doctor at some point, because there are adult things we need to worry about, right? So, and at some point, I think that the level of what we can do in pediatrics is limited, right? Even in those cases. But I think that helping families with that transition is really important, particularly in the case where we might have a young adult who's got some delay or some disability.
Talking about teenagers, usually the immunizations and everything happen, within a close period of time, and then you get into this more adolescent stage where there's less vaccinations needed. They need the doctor less, in a sense. They're not necessarily sick all the time. So how often does a healthy teenager need to be coming into the office for well-child checks?
So I am still a fan of having them come in once a year. And I say that for a number of reasons. They don't need to come in every 3 months or every 6 months. We're not giving a whole lot of vaccines, as you said, in that time. But there's a lot of checking in with teens to see how they're doing, again, with school performance, because those are things that can come up every year. We need to be sure that we're checking in on mental health for teens, and we'll talk a little bit about that more towards the end of the talk, I think, tonight. And I also think that it helps to model for our teenagers in particular how we are forming relationships with our healthcare providers, because that's a skill to be learned, right? So it takes some time to understand the questions to ask. It takes some time, particularly if you have a chronic illness, to understand how to manage that, right? And so we can practice year after year with our teenagers. You mentioned earlier that we often will have parents step out of the room. I do that in my teenage visits. And I will tell parents, when I am seeing a teenager for a well visit, we'll start all together. And then I will have the parents step out of the room and I'll talk to the teenager one-on-one. And then I'll bring the parents back in and we'll talk all together. And I really do that for two reasons. Number one, I do think it's important that we have an opportunity for our teens to speak confidentially with a healthcare provider. Not all of them want to talk about what's going on necessarily with mom and dad in the room. But even outside of that, I think that having a teenager have a chance to speak one-on-one with me is starting to empower them to understand how it is to have a relationship in healthcare and to kind of take ownership of that. Again, that's not something that happens overnight, but I think that those yearly checkups can allow for that as well.
Yeah, and I think another thing, it's a good thing for those who have adolescent children to get your child in the habit of speaking on their own. Because a lot of times what happens when we get our adolescents and they're, I say, so why are you here? And they look at mom or dad to answer for them. So I usually try to stop that. And sometimes parents are enablers, and so they'll try and keep answering. But I usually will try to stop them and say, hey, in 2 or 3 years, you're going to be out on your own. You need to speak for yourself. So you want to get a habit of not speaking for your child. Let them speak. Because sometimes they'll say something different than what the parent will share. So you want to get both sides. But just, like I say, get a habit of them speaking on their own. So sick visits. So, the parents run the gauntlet of when they bring children in for sick visits. Some people, they bring their kids in for every little scratch. And other people wait till their child is half dead to bring them in. So it's a spectrum.
I wasn't going to say that, but okay, yeah, there you go.
It's true, though. It's true. So, what I want to talk in the next several slides, and hopefully the media team can just progress it as we go from one disease process to another. What are key signs or symptoms that you think you should actually, the parents say, okay, now we need to take you to the doctor?
That's a great question. We do see the gamut, as everyone in here, and as the laughter probably suggests too. I think there's a couple of key points that I would highlight here. Number one, off the bat, I would say for a newborn or any child under 2 months, particularly if it's your first baby, if you have any concerns at all, pick up the phone and call or bring them in, right? So certainly with young babies kind of under the age, again, really 2-3 months, they can't always show us exactly what's going on, but if they're not eating right, if they're not breathing right, certainly if they have a fever, I would pick up the phone and call and bring them in. General guidelines outside of the super young kids, I would say, high fevers, usually I say above 103, 104, particularly if it's been going on for a couple of days. Most viruses, and we'll talk a little bit about viruses here in a few minutes, most viruses can cause high fevers, right? But they usually will only last a couple of days. So even a virus that's going to cause 102, 103 temperature, usually that's going to be done with itself with that temp many times 2 or 3 days. And if we still have fever beyond that, then we start to wonder, maybe there's something else going on, maybe there's not, right? But that would be a time that I might pick up the phone and call. I think that anytime you have concerns about your child breathing, or if their breathing looks or sounds unusual to you, that's a reason to call, right? So kids get lots and lots of colds, and we know that, and we'll talk about that here in a moment too. But if the breathing, particularly the chest breathing, right? Like if the chest breathing looks different, I would call, right? Other things that I often will say, if you have a child, vomiting and diarrhea is common in kids. We all see that as well. But if you have vomiting and diarrhea that's going on, particularly the vomiting that's really going on nonstop, or if your children haven't urinated in a 12 hours, 24 hours, that can be a sign of dehydration. That's something I would call about, right? So just like you and I, if we're dehydrated, you're out hiking on a day like today and you're hot, you probably don't go to the bathroom as much. We don't make enough urine. The same is true for kids, right? We use urine output as a real marker for hydration. So if you have a child who hasn't urinated in 12 hours or longer, I would pick up the phone and call. Kids who are in severe pain, right? If you've got severe abdominal pain, that's usually a little bit of a red flag. I'd bring them in. And then the last thing I often will say is if I have a change in behavior for whatever that looks like. Now, in young kids, they may just be doing something different that they don't usually do. But in older kids too, if their behavior looks off, I would bring them in. I think at the end of the day, I will often tell parents, trust your instincts, right? If something seems like it's not quite off, pick up the phone and call. And again, that's where like a good relationship from all those well visits you've been going to, that's where a good relationship can really pay off, right? So.
Perfect. So if we can go to disease 1, I'm going to get to you, Mother Nydia. We got a lot of slides I want to try to get through. It is viral. It's still, even though it's 100-some degrees, we still got viruses going on. I know people in the audience know that firsthand. But can you talk about viruses or viral upper respiratory infections?
So we'll talk through just a few of the common common viral infections that we see. And the first one we start with is just the common cold, right? So, which maybe half of us have in here tonight, right? So the common cold is about 50% of pediatric acute care visits, right? So sick visits for kids. Almost half of them sometimes are related to the common cold. So those are viruses. There are many different types of viruses that can do that give you the signs and symptoms that we all know, the runny nose, the sore throat, sometimes a fever, sometimes a cough. The challenge there is that sometimes those viral infections, those symptoms can last upwards of a week or two, right? So it's feeling really miserable for a few days, but it can take a while for those things to get better. The thing that I would highlight about that is that because they're viral, antibiotics don't help. Now, the challenge there is that, okay, well, I feel miserable, so what can I do to make myself feel better, right? So, and that's really where we'll talk about things like Tylenol, like ibuprofen or Motrin. If kids are older than 6 months, we'll do that. If kids are really snotty, we'll suction out their nose, right? We can run sometimes a cool mist humidifier in the room if they're really coughing. There's some studies to say that you can give honey to kids over a year, right? We don't give honey to kids under a year, but honey can sometimes help to soothe a cough sometimes in kids. So that's something that sometimes I'll have parents try. We really caution against using cough medicine for kids under 4 years old, right? So, and there's a lot of cough medicine on the shelf. So if you go to CVS or Walgreens tonight on your way home, you're going to see a lot of cough medicine on there for kids. It's not really been shown to be helpful for kids in terms of their symptoms, and sometimes there's a risk of kind of taking too much. And so I would really caution, certainly under 4, and really in many children, I would caution against a lot of cough and cold medicine, just because I would focus more on some of the other things that are listed there. So.
All right, we'll go on to the next one. And we're going to do a little speed run through some of these common things here, just a matter of time. But yeah, let's talk about ear infections. That's definitely a
Let's talk
common
about
one.
ear infections. So ear infections are super common. Usually what you'll get with an ear infection is a virus, like a cold that starts. Then you're going to get a lot of fluid that builds up in the ear as a result of that virus. And then sometimes you can get a bacterial infection that sets in on top. And that bacterial infection is inside the fluid in the ear, right? So again, that's the usual story that we'll get. Sometimes we'll do antibiotics for ear infections, particularly if kids are younger than 2. Sometimes there's been, in an effort to try and be sure that we're being very prudent and judicious with antibiotics, sometimes we'll watch and wait depending on how bad the symptoms are. So there's a bit of a gray zone, and you can talk to your pediatrician or your family medicine doc about that. The picture on the left that you see up there is a normal eardrum, in case anybody's ever wondering what are they looking at when they're looking in my kids' ears. So on the left, you see a normal eardrum, and on the right, you can see a red and angrier eardrum, hopefully, right? That one on the right is an ear infection.
Whooping cough.
So whooping cough is another common infection that we see. This one is actually one that is bacterial, right? So there's actually a bacteria, it's called Bordetella pertussis, right? Pertussis is the medical term you'll hear for whooping cough. But I threw it in here tonight because this is a vaccine preventable illness, right? So in the vaccines that your kids get at their well visits, they actually get vaccines against whooping cough. But sometimes we see outbreaks of whooping cough, particularly when our vaccination rates are low. And I will say that I have seen 2 kids with whooping cough. One was in a school and exposed to whooping cough, and the other had whooping cough within the past 2 months. So it's around from time to time. The reason we worry about it is because it can cause some common cold symptoms, but it also causes a very severe cough. A cough the kind of cough that's so strong that you often will vomit afterwards, right? So, and particularly for our young infants, that can be a real problem. Sometimes that can lead to seizures in newborns and even death for kids who get pertussis as an infant or a newborn. This is why if you are pregnant or if you have children or grandchildren in the audience who are pregnant, we will sometimes often recommend that our pregnant moms get a Tdap vaccine during their pregnancy. That Tdap vaccine protects against pertussis. The P in the Tdap, that's the pertussis component to that. And we recommend that moms get pertussis during the pregnancy so that they can start to make antibodies against pertussis and then pass those antibodies to the baby in breastfeeding, right? That's the mechanism by which we do that. And so again, because it's high risk for newborns, that's where that recommendation comes from. It's also why if any of you have been told by your children or grandchildren that you need to get a Tdap to come see the baby, that's where that's coming from, is because we're trying to minimize the risk of pertussis in infants.
Sure. Thanks. So we talked about ear infections. What about throat infections or pharyngitis?
So pharyngitis, sore throats are really common as well, right? Sore throats, of course, can be caused by either viruses or can be caused by bacteria. The classic bacterial infection for a sore throat is strep throat, right? So, but not all sore throats are strep. This is one case where I would say it is important if your child has a very severe sore throat, especially if they don't have any other cold symptoms. That is a time when I think it's important to kind of come in and maybe have them checked for strep. Strep throat, as many of us know, will have a high fever. It will sometimes have the white spots on the tonsils, right? Sometimes we'll get some swollen lymph nodes in our neck, but there's usually no cold symptoms. There's usually no cough, there's no runny nose. It's really just the sore throat. And that could be strep. Strep throat is a bacteria. We do treat that with antibiotics. And the reason for that is to treat the bacterial infection, but also to prevent some of the complications that can come after strep throat, like rheumatic fever and things like that. So again, if you've got a really severe sore throat and no cough or cold, that's a time that I would have your child come in.
Croup.
So croup, croup is not fun. And if there's any families in this room who have had a child or a grandchild with croup, Croup can be a little bit scary, right? Croup is caused by a virus. So again, this is another viral infection that can cause swelling generally in the larynx or this kind of area in the neck. And that's why, because we get swelling and infection here in the neck, that's why it gives us that kind of barky cough, or you almost sound like a seal, right, when you're coughing. And the scary thing that I think is scary about croup is that the symptoms are often worse at night. We're not exactly sure why that is the case, but the high fevers and the barky cough often comes at night, and it can be very frightening, of course, because your pediatrician's office is not open, right? Or your family medicine office is not open. Antibiotics generally are not helpful for croup because, again, it's a virus that's causing this. And so, again, it's Tylenol, it's ibuprofen, it's fluids, it's that cool mist that we talked about. If kids are really struggling and your child sounds like they're really having trouble breathing, and it's in the middle of the night, if you take them in to the ER, sometimes there are medicines that we will give in the ER a little bit, steroids and things to help calm it down. But many times those symptoms will improve with time, and usually it could take up to a week. It's just a bit of a scary week, I think, because, again, of the nighttime component to it.
Then RSV or bronchiolitis.
So RSV is a hot topic, right? So RSV, of course, is a virus that tends to cause, kind of moving down, we talked about the common cold, we talk about croup. If we move down a little bit, RSV is a common virus that will cause some inflammation down in the lungs, right? So it can cause some cold symptoms, but what's classic about RSV is that it causes the inflammation down in the lungs themselves. That's what leads to the more severe trouble breathing, and that's why RSV is the cause of putting kids in the hospital a lot, especially young ones under the age of 2 years. Again, it's a virus, and so antibiotics don't generally help, right? What does help for these kids? Again, Tylenol, ibuprofen. If the kids are sick enough and they're breathing fast enough, that's generally what you'll see with kids who have really severe RSV. They'll start to breathe really quickly, and it looks like they're breathing with their belly, right? So if you've ever seen a child who looks like they're really struggling to breathe, we will treat them with oxygen, of course, if they're in the clinic or they're in the hospital. There have been some advances in RSV treatment over the past year that we will probably hear more about. There are, because it's so widespread, we've been doing a lot of research over the past 15, 20 years to try to say, could we get a vaccine for RSV? What we do have on the market that's come out over the past 2 years has been, number one, a vaccine that we can offer to moms during pregnancy. Same idea with the pertussis, right? So that we could give that RSV vaccine to moms during pregnancy. And number two, there is now a medicine that we can give to babies in their first year of life that can help prevent RSV. There were big problems last year with supply for those medicines, so they haven't really been rolled out as widely as we might see them again this year. RSV season is usually wintertime, so we'll see what the season brings for us this year.
Switching gears, asthma. You could spend a whole night on asthma, but we want to talk, just give you some highlights about things that parents should be thinking about if their child has asthma.
Yeah, we could spend a whole night talking about asthma too. Asthma is a little bit different than some of what we talked about before because asthma is really a chronic illness, right? The other things we talked about before, common illnesses, but they're usually more acute, right? They're sicknesses that you recover from, get over. Asthma is probably the most common chronic lung condition, certainly in pediatrics. It is more common in certain populations, African American populations included. We're not entirely sure why that is the case. There is studies being done on that. But I think the high points I would bring out about asthma would be asthma is an illness that commonly has triggers, right, that we will try to identify. So sometimes those triggers are illnesses. Sometimes those triggers are allergies. Sometimes those triggers are cold weather. Sometimes those triggers might be exercise, right? There can be things that trigger your child's asthma, and trying to minimize those triggers can really help. So that's point number one, I would say. Point number two is that good asthma management really is a family affair, right? So it takes a lot of education of families to understand how asthma is chronic, and why these inhalers, maybe even if your child seems to be feeling well, why some of those inhalers might still be necessary to take every day. Sometimes it's easy, out of sight, out of mind, to stop treating things that don't seem to be such a problem. We can get into trouble, though, with asthma with that, right? Because asthma is really best managed on a more chronic, long-term basis. So it's important, really, to talk with your child's care team about what that looks like. Even if he's not coughing, do I still need to do this, right? It's important to have those conversations. There's a couple of pictures up there that sometimes the other thing I will say about asthma is that it's not always intuitive how to use the inhalers, right? So if you have a child with asthma, be sure that you are using those spacers, which are the little tubes that you see up there. Make sure that you're using them. And if you don't know how to use them, ask. There's no harm in that, right? So ask, hey, should I be using this in the right way? How many times, how many puffs am I supposed to take? Don't be afraid to ask those questions, because it's really family education that's really key in asthma.
There is a question online, but Mother Massey had a question. I want to start with her, and then we'll go to our online question.
We'll start with Mother Massey.
Yes, you had said something earlier about dehydration, the way to identify it if a child has not urinated in so many hours. How about bowel movements in infants? Like 6 or 8 hours, is that a concern?
That's a great question. So the short answer is no. I would say bowel movements in infants, there's actually a lot of variability in that. So I'm glad you brought that up. Some infants will have a bowel movement multiple times a day, right? So some infants will go multiple days without a bowel movement, right? So depending on the infant. And while the child can be uncomfortable in those settings, right? So especially if we're upwards of a week, let's say, right? Because I have a couple of babies that they go once every couple of days, right? And we'll go upwards of a week that I have seen. It's very rare, though, that children get so backed up, right, that it becomes a medical emergency, if you will, right? So now, once we get to that point, sometimes we'll talk about what can we do to try to stimulate a bowel movement. Sometimes, especially in my newborn infants, we'll do like a little glycerin chip or a little rectal stimulation, right, to try and see if that will help release the poop, right? But to your point, if they go a couple of hours or even a day or two without a poop, that's okay. So that is very different, though, to your point, than the urination, right? We don't want kids to go a day without urinating. That's a much more serious situation. So.
The question online is they're asking, when would you consider tubes for kids who get a lot of ear infections?
So that's a great question, right? So we consider, so tubes for ear infections are considered for kids who have multiple ear infections over a course of time, right? So the guidelines have changed a little bit sometimes over the past couple of years, but many times, broadly speaking, we'll think about if a child has maybe 3 separate ear infections over a 6-month period of time, or sometimes if they have 4 infections in a year, right? Then if that's the case, if children are getting recurrent ear infections despite doing the antibiotics or despite being treated appropriately, we know that if we let that fluid build up in the ear, sometimes that can affect a child's hearing and therefore affect their speech development early on in childhood, right? And so sometimes then we will think about putting tubes in the ears, right? A tube in the ear, remember those pictures I showed you of the ear infection, right? The red eardrum. Essentially, a tube is just a small little tube that goes right through that membrane, right through that, basically the wall. So if you stick your finger in your ear right now, what you're hitting with your finger is your eardrum. And if you have a child who has tubes in their ears, essentially there's a tube that's placed in there that just connects the inside with the outside, and it allows the fluid inside the ear to drain. right? And that prevents the buildup of fluid, and it allows children to hear and then develop their speech normally, right? So children, the tubes then will naturally fall out on their own with time, and then once they fall out, the eardrum will heal itself. The body is an amazing thing, right? Such a beautiful design by God. So that will go ahead and heal itself with time. But that's a long answer to the question about when do you put tubes in. So, but usually it's a number of ear infections over a period of time.
We're going to skip over obesity. It's just a matter of time. Because,
Okay.
again, I think we'll have a whole night on pediatric obesity.
We can come back to that.
Yeah, we
for
can come
sure.
back to that. Adolescent mental health. I did want to end on it because that's a critical thing that's going on. So let's talk about adolescent health, what some of the most recent numbers say about adolescent mental health. What is that looking like?
So I do think it's worth kind of finishing out tonight talking a little bit about this. This is a growing problem, right? So we know that mental health disorders, depression and anxiety in particular, are becoming increasingly common, right? Depending on the study that you quote, certainly anywhere between 5 and 10% of kids, of teenagers will identify as having depression at some point, and we know that that is increasing with time. There's been a lot of talk about adolescent depression and anxiety since the pandemic, and while I think that the pandemic certainly didn't help, right? I actually think that a lot of these trends were present even before that time. So I don't think it's just about the isolation that we saw during the pandemic, though again, that did not help us. There certainly are some risk factors that we have identified, things just to be aware of. Young women are about twice as likely to be diagnosed with depression as men. Certainly, we know that if there's a family history of mental health concerns, depression, anxiety, that predisposes our young people to it as well, just as many other chronic health conditions. We know that if there's family conflict, if there's divorce, if there's discord between parents, that can put our teenagers at risk for depression and anxiety. We know that if kids are have early exposure to tough situations, right? If the home's not very stable, particularly for our young kids, that can put us at risk for depression and anxiety down the road. We know that if kids are struggling with school, if they're struggling with peers, and we also know that if kids are managing chronic illness in childhood, those are all risk factors for concerns about depression and anxiety in kids. And so I do think that this is, again, whether you're coming in for your well visit at whatever age, this is an important thing that we want to be mindful of and that I am always asking about when I'm seeing families and adolescents. So.
Yeah, so the pandemic did change a lot of things in how we interact as members of the community. And so even as you look in our department, one of the challenges I had taking over the department was that people had went underground, and I had to really work for a long time trying to get people out of that rut of, not having cameras on, not coming to meetings in person. So, I see that also in our adolescents, even how they interact with each other. I was talking to my son maybe sometime last year, and we were talking about dating and things like that, and he was kind of explaining the dynamics, which is way different than obviously when I dated, and how the difficulties, some of the challenges come because of how they interact. You want to talk a little bit about that?
So I think, yes, I think that the challenges of living in a really a digital world where so many things regarding relationships and human interaction is done online, definitely doesn't help our case when it comes to mental health. I think that when we try to think about why are we seeing so much more depression now, there are probably many reasons, and we're still trying to figure that out because we don't have it all answered. But certainly the advent of social media and the advent of relationships, the nature of relationships, we're made for relationship with one another. And I think that when we are taken out of that, Zoom just doesn't do it, right? So, and I think too that with the advent of social media platforms, right, that that has had a very negative impact on the way that our teenagers interact with one another, how they cope with things, how they view themselves in the world around them, right? And I think we are in dangerous times sometimes if left unchecked. To be honest, I think a lot of this has been happening for years, and it really is only recently that in kind of the larger mainstream media, we're starting to get some recognition that this is a problem, right? So that we know that social media use is a risk for depression and suicidality. We know that if you pick up your phone more than a couple of times a day to look at things as a teenager, that's a risk for depression. Those studies are starting to get talked about even outside of communities like ours here tonight, right? So, and even some of these pictures up here, you know, our relationships with one another, the ways that we have changed over time, it's been a bit gradual. You know, we used to, everything was outside, right? Come in when the street lights go on, you know, that kind of thing, right? That was a long time ago, right? It used to be even 20 years ago that the only digital things we saw, the only screen time we had to worry about was movies, right? So, and then we saw the advent of a lot of gaming, right? So, and now everybody is on a device, sitting by themselves, totally not engaged with the person sitting next to them. So, and that is the trajectory that we've seen, right? And I think we have to be really cognizant of what that can do if left unchecked, right? So I think, yes, it's here to stay, but I don't think it means that it has to be all doom and gloom, right? So.
Yeah, a couple things I was looking at preparing tonight. So the most recent stats say that on average, a teenager will spend about 7 hours and 22 minutes on screen time a day.
Yes.
Which is about 43% of their waking hours on screen time. And I don't want to paint the picture that screen time is all bad, because all screen time is not bad. It depends on what kind of screen time, what you're doing on that. One interesting point is that if you look at some of in the Silicon Valley, there's just been movement for some years now of them sending their children to tech-free schools. Doesn't mean that they keep them from any screen time at home, but when they're at school, there's no screen time. And what's interesting about that is that when, you know, technology was coming forth and we had laptops and internet access, there was a lot of pushback because of disparities. Or say, well, people who don't have the money to have internet and have phones and iPhones, you know, they're not getting the benefit of that. But what's come now is the people that can least afford to be on media, social media, they have access to that. They have iPhones. But then the rich are saying, well, we don't want all of that. And I think, you know, even if you look at China and the move with TikTok, and they're like, hey, we'll make it, but we're going to control and regulate what product our own community gets, but we'll send it to America and you guys can have it all. Knowing, I mean, it's a smart move on their part, but understanding that, you know, moderation is very important. And that's a hard thing, I think, as a parent, because I'm a parent. My kids are almost out the house now. But, you know, it's easy to give them that particular screen to, you know, you're busy, you're tired, and they want to be entertained, so you give them that. Can you talk a little bit about what is the current recommendations for parents as far as screen time?
Yes. So I would definitely agree that not all screen time is bad, like you said, right? So I think it really comes down to us as parents, and I think that's part of our job as parents and our job in healthcare as clinicians to really help guide parents on that. So the American Academy of Pediatrics has come out with recommendations on screen time that really vary based on age. So current recommendations are that if your child is under 18 months, that they really should not be on a screen unless they're doing FaceTime with somebody, right? So FaceTime with grandma and grandpa or something like that. Now, between 18 and 24 months, then the AAP uses the word high quality programming with parents. there's not a lot of definition given to that, right? So, but that is the terminology given. I think the idea behind that, right, is that you don't want to just give your child a tablet, right, and just let them spend all day on it. That you really want to be mindful of what they're watching. Kids between 2 and 5 are recommended to have an hour a day of, again, that high quality programming is what they're talking about. And then kids 6 years or older, the terminology is written consistent limits on the time spent during using media and the types of media, which is really gray and very nebulous, right? So I think that there is, to your point earlier, Dr. Pullins, dinner has to get cooked, right? So there are times when, like, you know, if my child watches a TV show or is doing something on their computer, that's real life, right? And so we're managing things. But I do think this highlights the importance of really being mindful. An hour is not a lot of time, right? So, and really, it's actually incumbent upon us as parents to set those limits and to be consistent with those limits. And as a parent myself, that is hard. That is really hard because we are working hard and we are tired at the end of the day, and it is much easier to just give in. And I think sometimes it's easier to just say, you know what, this is just the way it is, this is the way kids are. But I honestly think we have a lot of room for ourselves as parents to kind of take that responsibility and say, no, we are going to talk about this, and we're going to do this the right way, and we're going to be consistent in it.
I want to jump to the summary slide because I want to leave a little bit of time for questions. So I think the summary slide kind of gives us a overview of everything you talked about tonight.
So just to summarize, and then we'll absolutely take questions. So well-child visits, don't forget to go, right? So, and I really do think they're important even as your kids age for all the reasons that we talked about earlier tonight. When you are concerned about your child being sick, trust those instincts, right? Particularly in your itty-bitties, but for sure, if you feel like there's something really off with my kiddo, make the call, bring them in. Kids are usually really resilient and usually don't need antibiotics. So again, it is unpleasant to have the sick kids, but a lot of viral things your kids will recover and do well from. I want to be mindful of depression and anxiety in your teens, even mild symptoms if you have concerns. I think the take-home point that I would have tonight would be invest the time in the relationships with your teenagers. Those 10 p.m. conversations that you mentioned earlier tonight, Dr. Pullins, that's the time of day, honestly, that I am the most tired. I am ready to collapse in bed and call it a day. But the time that you invest in being the parent, there's no substitute for that. Your kids have lots of friends. They need the consistent limits. They need the parent, they need the parental figure to help guide them, especially in those teenage years when the brain is still developing, right? So, and I would say, do not be afraid to stand up and say, you know what, we're gonna do this differently as a family, and we're gonna have a conversation about it, and we're gonna have multiple conversations about it. And I think that's where I draw my hope from, is to say that not all is lost. Depression is on the rise and kids are using their phones, but I feel like if we can stick to those, that we are on the right path.
Thank you, Dr. Kruger. Questions?
I'd like to start, Dr. Kruger, by sharing one of the things you pointed out earlier were having the information and the right questions to ask your provider when you're taking your child to the doctors. And I also would include that the parent should do a very thorough assessment, because some of those diagnoses that you pointed out were very similar to each other. So I think it's important as parents, and I'll reiterate, that they should make sure that they ask all the right questions. And because of their apprehension and the anxiety that they may experience when they're bringing their child to the clinic or to urgent care, they may want to write a lot of that stuff down so they'll be prepared to provide that information to the provider, right?
Absolutely. Don't be afraid to make a list, right? So I have people come in all the time. I'm sure Dr. Pullins does too. I'll say, what can I do for you? Well, I made a list. Okay, good, right? So then let's get to it, right? But that's how we ensure that we are addressing all of the concerns, and it also helps, yes, to have us as parents think about those things, make sure that you include everything that you want to address coming in the door. Absolutely.
I have a question about puberty. It said that girls are starting to hit puberty younger and younger because of like food hormones and things of that nature, diet. Is there a way to help prevent that happening in younger girls?
So that's a good question. I would say that there is a range, right, for both boys and girls to go through puberty, right? So, and that range is pretty big, right? Like some girls will start puberty as early as 8 or 9 years old, right? So, and then some girls really won't start puberty until much later, right? Sort of 13, 14, right? There has been a trend that has that can sometimes edge us or push us towards earlier onset of puberty. We see that sometimes with other conditions. We didn't talk about obesity tonight. We can always do that. But sometimes childhood obesity in some of my heavier kids, my kids with obesity, sometimes that will predispose my girls to go through puberty at an earlier time, right? There is not a lot that we do to purposefully delay puberty in those situations. But what I would say is that's an example of why it's important to maintain a healthy weight, healthy food habits, healthy exercise habits, and involve the family in those conversations, particularly when we're talking about healthy weights in kids, right? And then sometimes that will help us to at least keep us in the right range for puberty, if that makes sense. There's also a lot of other things that go into puberty, including the age that your family went into puberty and things like this too. So there's a lot of factors at play. But I think if we're talking about something we can intervene upon and do to change it, I think focusing on healthy weights for kids is probably the most helpful and tangible.
Yes, my question is about diet as well. When I worked in a K-12 environment, I noticed some of the younger kids, in the mornings, they would be bouncing off the walls. And after lunch, they would sort of tone down. Now, teachers were throwing out ADD, but when we asked what the kid had for breakfast, the cereal was loaded with sugar. So of course they're going to be hyperactive. So how do you convince parents that what they're feeding their kids for breakfast is going to determine how that kid functions during those first few hours of the learning process?
So that's a tough one and a really important one, right? So because you're right, I think food and diet plays a huge role in so many things. Yes, purely on the growth side of things, but also on various aspects of development, including how they do in school, for sure. And that's one of the reasons I would say why it's really important that I, as a pediatrician, Dr. Pollins is a family medicine doc, that we are touching on diet at every single opportunity we have, every well visit that we have, to talk about, and again, sometimes getting nitty gritty. How's your diet? Good. Well, that's not helpful, right? Like, let's talk about, what did you have for breakfast this morning? I will often ask kids that, right? So, and then sometimes the parents are really embarrassed because it is a really high sugar food or whatever the case is. But I do think one of the challenges that we face, right, is that sometimes healthy food is expensive food, right? So some of our families don't always have great access to a lot of that. And then sometimes I have to lean into families to remind them to say, what kind of an example are you setting yourself, right? So the importance of family meals cannot be underestimated, right? So when it comes to family dinners at night, if that's possible, and setting out a healthy example for a healthy breakfast in the morning is also really important too. Again, it's modeling what you want. So I think it is important to engage with parents on that question, right? And to do it often and early so that you're setting yourself up for success. I remember my own son would not eat any vegetables come like the age of 18 months or 2 years. And then my pediatrician said to me, how many times a week do you cook vegetables for dinner? Right? And then I had to really think about it, right? And then it was at that point that I thought, gosh, you got to walk the walk if you're going to talk the talk. And so those kinds of questions, I think posing those kinds of questions to families on sometimes a very granular level can really help.
That's a good question. One of the things I also want to point out when you talked about social media, and I started smiling because I'm doing a study now at the hospital regarding that in adolescents. Unfortunately, there's not enough evidence yet to determine the impact of social media. I'm in the line of neurology with dementia, and so we don't, because of 18 years or less, we can't really show the evidence. But I appreciate the fact that you said the statement regarding the consistency, especially with those 6 years of age and older. And I would also say I watch my niece and nephew every once in a while, and it's funny because my nephew, who's 3, the parent would give me a list of food he can't eat, what he's going to do when he goes to sleep. But the 10-year-old niece, I said, do I have a list for her? He says, no, just give her the tablet or the phone, she's okay. And that's what we hear often all the time. So I think as parents, if you're going to do, like you said, walk the walk, if you're going to do it in your home, then you need to do it also in anyone else's home. So as you probably can imagine, I set the limits in my home when it comes to television and phone.
I think we just have to. I mean, I think, and I see that in the office sometimes too. And it's hard. I'm a parent. It's hard to be I'm the only one who sets limits. I'm pretty restrictive. I let my son have 30 minutes a day. He's 14. He has the phone for 30 minutes a day and no social media. And he says, nobody else's parents do that. And I said, well, you don't have anybody else's parents, right? So, I mean, it's, and everybody comes to their own space. So that's just the way that we have done it. But I think that setting limits, I think kids in general, right? When it comes to social and emotional development, our children respond to limits at the appropriate times and in the appropriate ways. And so I would encourage us not to just abandon things to social media and just assume that this is the way it is. I really think that that is part of our calling as parents, right? Part of our vocation as parents is to really guide and shepherd our kids. And I think this is an area that we are called to do that too.
That is a great place to end, Dr. Kruger. So thank you for coming and sharing tonight. We'll have you back again. Maybe we can spend the night on pediatric obesity. But let's give Dr. Kruger a hand, please.
Thank you.
So thank you for coming out tonight. I would say if there's other parents that you run into during the week, let them know that this topic took place, and so they have questions or want to view the video stream, that we'll have that. On next week, we will have Dr. Alyssa Chapatal, who's one of our ICU/surgeon/ administrator, come in next week and talk about ICU 101. And so we'll spend the night kind of talking about what happens in the ICU, what to expect, questions you may want to pose to an intensivist if you're ever in the ICU. So that'll be on next week. So we pray that you can come out and be present for another great night of great information that you'll be able to share, not just with your household, but across the country. So with that being said, we are going to relieve our stand and go down, and we're going to ask that the leader, the reason why we're here tonight, Dr. Logan, to come up and give us final remarks and close out in prayer. So let's give him a hand as he comes.
Let's put our hands together and thank Dr. Kruger and Dr. Pullins for an outstanding job. As I listened to the presentation, the thing that became evident to me is how complex life has become. And I think to navigate through the complexities that we face now, it's important that you get information. Because with the information, you're able to determine how crucial it is that you limit, say, social media, that you're aware of some of the challenges that children face in life that's causing them to be depressed. And you can deal with those things a whole lot better if you're informed. I think it's important that in the church that we have these type of conversation, because people tend to bury themselves in the spiritual realities, not realizing that all life is connected. And so it's one thing to be spiritually astute, but you need to be financially astute. You need to be astute in terms of your health, your mentality. All of these things are important. So again, I want to encourage you to avail yourself so that you can be an informed parent. And with that information, not only can you tell your kids what to do, but you can also tell them why they should do it. And the ultimate challenge that we face, where the spiritual component is so important, is that it was mentioned, if you're going to tell your kids something, make sure that you're not doing the same thing yourself. And I think the spiritual dimension will help you in that regard, because it'll help you to have a more integral approach to life. But it's a challenge. You're tired, you're working hard, you're trying to provide a full life for your family, and sometimes these little things we tend to disregard. But Scripture tells us it's the little foxes that spoil the vine. And so little things can become very important if they're not managed properly. What you eat, what you watch, who you associate with. The Bible addresses all these little things, but when you couple the Scripture with other disciplines, sociology, psychology, as we see tonight, getting your children checked out early, that's very, very important. I'm really concerned about those who are ignorantly pushing aside the vaccinations, and I'm seeing old diseases become more prevalent, and I'm really concerned about that. And so tonight we were given some information. Use that information to help people who might not be informed. Do you think that's a good idea? Again, thank you, Dr. Kruger. Thank you, Dr. Pullins. Thank you, Dr. Allen, for helping us to be informed, to be knowledgeable, and ultimately helping us to be better. We're standing. I would ask that you remember those who are going through various trials in their life. The beauty of the church is that you're in a loving community. So allow the love of Christ to motivate you to reach out to people that you haven't seen, and just let them know that you're concerned. A phone call can be a life-giving thing to someone that's suffering. Amen? Father, we thank and praise you for this day. We thank you for Dr. Kruger, Dr. Pullins, Dr. Allen, who've devoted their life to health care, to help us to live healthy and productive lives. For that, we're grateful. Now, Lord, we pray that you would just continue to bless them, their families, allow them to progress in their respective fields, oh God, in a way that will help make our community better. And Lord, I pray for all that are listening, both here and online, that you realize that the information that you're receiving is so important. Help us to hold on to it. Help us to see value in it. Help us to take what we have learned and share it with other family members and other friends that we might know. We're believing you that if we know, then we are able to do better. So, Father, we are just trusting you to help us to humble ourselves so that we can receive from people who are more knowledgeable than us. Help us to realize, oh God, that the choices that we make can have life-changing consequences. So, Father, help us to make good choices, informed choices, godly choices. We ask this now in the precious name of Jesus. And all of the people of God said, amen. God bless you. Greet one another tonight and just let them know that you love them with the love of Christ. God bless you.